Hi, I'm Karen Peterson, the Vice President of Programs for the Prevent Cancer Foundation. And on behalf of the Foundation, I would like to welcome you all to our second webcast of the 2020 Virtual Prevent Cancer Dialogue. We have a very exciting session planned for you today. And to get started, I would like first to introduce Dr. Bernard Levine, who is our moderator for the panel today on innovative technologies in cancer screening. Dr. Levine is Professor Emeritus at MD Anderson Cancer Center and also the co-chair of the Foundation's Scientific Research Review Panel.
Good afternoon to you from New York. I'm delighted to welcome you to the second session of the 2020 Virtual Prevent Cancer Dialogue, entitled Innovative Technologies to Expand Cancer Screening. As of Monday, we have over 1,000 registrants. Our format for today is as follows. We will hear from three distinguished speakers, one right after the other. Firstly, the eye breast exam from Dr. Peter Kingham, Global Cancer Disparity Initiatives at Memorial Sloan Kettering Cancer Center in New York. To be followed by the topic Screening for Oral and Oropharyngeal Cancer from Dr. Petra Wilder-Smith at the Beckman Laser Institute and Medical Clinic, University of California in Irvine. And then finally, the HOPE Project, Women Empowering Women to Adopt New Technologies for Cervical Cancer Screening from Dr. Nimi Ramunajam, the Global Women's Health Technologies at the Duke Cancer Institute, Duke University. Then I will be back and we'll have time for questions and answers. We will wait to address questions and comments until all presentations have concluded. A few organizational notes are relevant. The chat feature will be disabled during the segment. You can use the raise hand feature located at the bottom of your screen to indicate you have a question or comment, and we will enable the audio so that you can speak. Or you can ask questions and raise comments in the Q&A text feature located at the bottom of your screen. We will go to the raised hands first for your inputs and then to the Q&A text. Please do not use the chat feature for questions as we will not be looking at it. In one way or another, we will try to get as many of your questions answered as possible. I have no conflicts of interest relevant to today's meeting. We'll now move to our first presenter, Dr. Peter Kingham.
Thank you very much for having us here today. I'm going to speak about breast cancer screening in high-risk and symptomatic Nigerian women. By 2050, 70% of the predicted 24 million people with cancer will reside in low and middle income countries. There was a Lancet Oncology Commission on Global Cancer Surgery that we participated in, and one of the key findings was that the majority of cancer patients require surgical intervention. This rise in cancers in low and middle income countries is thought to be because of lifestyle changes, higher life expectancies, and improved infectious disease treatments. In response to this need, myself, along with Isaac Alatishe, pictured here, who is a surgeon and professor at Obafemi Awolowo University in Ile-Ife, Nigeria, founded the African Research Group for Oncology Consortium, or ARGO. This is a group of now about 25 Nigerian centers combined with my center, Memorial Sloan Kettering in New York. And our goals are really to focus on research, training, and treatment and outcomes to improve outcomes for cancer patients, perform clinically meaningful research, create a model that can be replicated elsewhere, and help with career development in Nigeria and MSK. We've decided to focus our efforts in a circle around the Nigerian cancer patient with 5 themes: epidemiology, biology, screening, diagnosis, outcomes, treatment, and access. Today, I'll discuss some of the work that has been done specifically on breast cancer screening. Across the globe, there's really a heterogeneity in how patients present. In the US, 5-year overall survival for stage 3 disease is 85%, and the majority of patients present with very small tumors that are found on screening exams. Whereas in Nigeria, the large majority of patients present with tumors that are 8 to 10 centimeters in size. And you can see that the survival in stage 3 patients is significantly lower when we compare it to the US. So there's clearly a big disparity in patient presentation and outcomes. Widespread population-based breast cancer screening of asymptomatic average risk women may not be feasible due to the required personnel and infrastructure for such an endeavor. There are limited radiology resources in Nigeria. There's approximately 300 radiologists in the country. Just to put that in perspective, at Sloan Kettering, we have about 200 radiologists just in our institution. In Nigeria, it averages out to about 1 radiologist per approximately 500,000 people. The US has about 50 times that. So because of that, we've been interested in how we can bolster the clinical breast examination. And are there ways to overcome these barriers with limited resources? So that led us to this study that I'm going to describe today, which was supported with a grant from the Prevent Cancer Foundation. And it's to focus on the eye breast exam, IBE. It's 510K FDA cleared. It's highly portable, handheld device. And it utilizes piezoelectric finger tactile pressure sensors at the head of the device to electronically palpate the breast. It can be used by community health workers with minimal training. And the purpose of the device is to assess for findings that warrant further evaluation. It does not distinguish benign from malignant lesions. So when it is placed on the patient and is calibrated, it then, all it reads is there something stiff underneath the device, yes or no? It doesn't tell you if it's benign or cancer. And in these neon readouts here, you can see that this would be an example where in the red square, that portion of the breast, the device has picked up an area that it feels is stiffer than another area. So our hypothesis was that the IBE may be a particularly useful screening tool in settings where breast imaging is a limited resource. So the study we designed was to provide high-risk or symptomatic Nigerian women with breast cancer education. And we wanted to evaluate participants with 4 exams: clinical breast exam, the IBE, mammography, and ultrasound. And we wanted the practitioners of each of these to be blinded to the results of the other studies. And our hope is that this study, which is a small pilot, can inform future screening efforts to decrease disparities. We also had some secondary goals to determine the efficacy of education on high-risk Nigerian women, what's their knowledge base currently of breast cancer and willingness to screen. We wanted to assess how easy it was and how successful we were at training staff, specifically community health nurses, to utilize the IBE device. We wanted to determine the sensitivity and specificity of the IBE for detecting breast lesions overall and for suspicious lesions, to compare the sensitivity and specificity of the IBE to clinical breast exam by trained clinicians, and to compare imaging and pathology findings of lesions detected and missing on IBE. So these are some photos of Lakan Olasihinde. Lakan was one of our PIs in Nigeria. He's one of the junior faculty members at Obafemi Awolowo. And this is a picture of him training 4 of the brand new nurses. They had recently just graduated from nursing school, and they were trained in how to use the IBE. So they previously had no formal training in clinical breast exams or breast cancer screening until this. Lakan traveled to Kenya for himself to be trained on the device, spent a lot of time with remote training, and then he became the trainer. There was a combination of didactic and remote learning, and they had to complete test patients prior to the study. Also included in the program is a breast cancer educational program. This is Lakan with some of the nurses at the Lagos site with an instructional program with educational materials that included lectures, videos, and print materials. We use a validated survey of breast cancer awareness measure that was a combination of a few surveys that have been validated around the world in order to assess patient knowledge. Patient recruitment was a big part of this. This was our first study that we were targeting high-risk patients with our definition of high risk as first-degree relatives of breast cancer patients. We have access to these patients because we keep a prospective database amongst our centers, and we do capture names and contact information of family members. So this was the first time we were trying to target both symptomatic women, but also high-risk patients. It was done at the breast cancer clinic at Obafemi Awolowo, is where we got the first 3 relatives, and we used radio jingles in English and Yoruba to advertise this. And these are some photos of Lakan and of Fumi. Fumi is one of the other junior surgeons at Obafemi Awolowo who was one of the main investigators in this study. So the patients underwent these 4 examinations. If a biopsy was recommended by any of the examinations, such as mammo and ultrasound, then it was performed, and treatment was initiated, if applicable, if a patient was diagnosed with cancer. And the imaging data were considered twice: positive for any finding, benign or suspicious, and positive for a suspicious finding warranting biopsy. We haven't completed our data analysis, but I can demonstrate some of the early signals of what we're seeing from this study. Overall, it was 424 women that were accrued. The initial target was 400. We initially had thought we would have 75% or 300 high-risk women and 25% symptomatic women. Our actual totals, it was a bit reversed: 35% high-risk, 65% symptomatic. We had to adjust our study halfway through because of the difficulties in getting access to these high-risk patients who are first-degree relatives, because they're really spread out over a wide geographic area. So this was an important learning point for us, as in breast cancer, colon cancer, other cancers, we're also trying to target this high-risk population. So we're learning a lot about how that can be done feasibly. The symptomatic patients had things like a small breast lump, breast pain or discomfort was in the majority of patients, nipple discharge. Additional symptoms were things like itching, tingling, axillary swelling, and skin changes. Some patients did report more than one symptom in the study. Just to give you an idea of the patient demographics, the average age was 48. The majority of patients were married. 92% have children, on average 3 children. The age of the first pregnancy was 26.5 years, and almost all of the patients breastfed their children. And these are important data because we think that protective factors for breast cancer are things like early first pregnancy, having a high number of children, and long-term breastfeeding. And we do find that the majority of Nigerian women with breast cancer have what we consider to be protective factors. So there may be other risk factors at play here. When we asked patients about their knowledge of breast cancer, almost all had heard of it. When we asked about risk factors, the answers were things like wearing a bra all the time. Half the patients thought that was a risk factor. 63% thought putting money in the bra or putting their phone in the bra for storage. 26% thought dirty air and water. So clearly there's a lot of room for some baseline education on breast cancer risk. When we asked about attitude towards screening and treatment, all of the women were willing to undergo breast screening and imaging. All thought they would do this regularly, and all said they were willing to undergo treatment of breast cancer. The few that said they were not, this was for financial reasons or religious beliefs. So the overall exam completion rate was quite high. As I mentioned earlier, our goal was for patients to have all 4 breast exams. 92.5% had all of them done. 32 of the patients missed either the ultrasound or the mammo or both. And 2 of the mammos we still don't have results for. The clinical breast examinations were performed by 14 different physicians. And this is an important part of the study, that the CBEs were performed by experienced physicians, and the eye breast exams were performed by nurses who were straight out of nursing school and had no real formal training on breast cancer screening. The average reported time for CBE was 2.7 minutes, and all patients had that completed. The IBE was performed by the 4 different nurses. It took on average 6 minutes, and all patients had this completed. When we looked at the overall positivity rate for CBE and IBE, the positive patients in CBE was 20% versus IBE 53%, and that's per patient, and per breast it was 10% in the CBE positive and 36% in the IBE positive. But probably more importantly is looking at the suspicious findings. And we did this on a per breast level analysis of any suspicious findings. And we found that the sensitivity was similar between the IBE and the CBE, and that the CBE, the clinical breast examination, demonstrated a better specificity. They had similar negative predictive values. There were some patients that had recommendations of biopsy. 37 of the 424 patients, or 8.7% of the patients, had biopsies recommended. 34 were based on imaging. They had BI-RADS 3, 4, or 5 findings. 3 were recommended by the surgeon due to clinical features without suspicious imaging. Of the patients that were recommended for biopsy, 5 were in the high-risk screening group, and 32 of the patients were in the symptomatic group. Of these 37 patients referred for biopsy, 30 had them, that's 80%. 15 of the 30 were malignant, 15 were benign. 7 biopsies have not yet been done because 3 patients were not reachable, 3 patients declined, and 1 patient is still trying to have a biopsy scheduled. There were 15 cancers detected, 15 of 424 patients, or 3.5%. Pathology confirmed breast cancer. This is clearly a very high number for a breast screening program, but it's key to go back to the entry criteria for these patients, which was either high risk or symptomatic. So this is not an average risk group. 1 of the cancer patients was in the high risk group, 14 were in the symptomatic group. And the clinical breast exam and the IBE both missed 2 of the 15 cancer patients. They missed the same 2 patients. Both had small tumors, a 1.7 centimeter mass on ultrasound and a 1.8 centimeter mass on ultrasound. So we're still working on the final analysis. We need to have longer term clinical follow-up on the patients who were screened negative to truly understand the sensitivity and specificity of the screening devices that we're looking at. We need longer term imaging follow-up along with clinical follow-up. This will enable us to do much stronger sensitivity and specificity calculations. We also would like to assess patient knowledge retention because there was patient education as a portion of the program. And we're now building a study to look at a much larger population of asymptomatic women and high-risk women. So fewer symptomatic women, because that clearly is a population that has a high risk of cancer already and ordinarily would go through a workup of their breast masses. Because the question that we still don't have an answer to is, does the iBreast replace a physician clinical breast exam in a rural setting? Because the findings here are that the 2 could be similar, and it may be that a way to rapidly build up capacity for breast examinations in rural settings would be to have replace an MD, experienced MD clinical breast exam with a more inexperienced healthcare worker's iBreast exam. And I think that question is really unknown right now. This study was a massive undertaking. We really thank Prevent Cancer for the support for this. Lakan Olasahinde, Leo Masori, and Vicky Mango, our breast radiologist at MSK, along with Isaac Alatishe, who is my co-founder of Argo, really put in all of the time and effort on this study. And in order to prospectively gather these patients in multiple cities in Nigeria and then do a per breast analysis in this rigorous way, I think these 4 all deserve major kudos for getting this done. We look forward to having our final results in the next month to be able to submit. These are our 4 research nurses who were a really key part of the team, and some of the rest of the Argo team pictured down below with Leo Masori and Lakan Olasahinde. And this is a picture of the whole Argo team at our last symposium in Nigeria last year. Thank you very much, and I'm happy to take questions.
My name is Petra Wilder-Smith, and it's a pleasure to be here with you this afternoon. I'd like to talk to you about some of our work on screening for oral and oropharyngeal cancer with a view to improving outcomes. This is a topic that my group has worked on for quite a few years, and it combines our clinical expertise with innovative imaging techniques and artificial intelligence. Oral and oropharyngeal cancer is the only major cancer whose outcomes have not improved over the past generation. In fact, tumors of the mouth and the oropharynx, or the back of the mouth, are some of the most frequent head and neck cancers that exist. Oral and oropharyngeal cancer is the sixth most common major cancer worldwide, and we are seeing quite significant HPV-related increases in its incidence in many countries worldwide. In the United States, there are about 150,000 new cases annually, with 400,000 people living with oral cancer and about 13,000 deaths. Worldwide, in some countries, oral cancer is the #1 cause of death. There are an estimated 2 million people living with oral cancer worldwide, and worldwide the incidence rates are increasing because primarily of HPV. In high-income countries such as the United States or Europe, 5-year survival is about 80% if we detect the cancer early. It is only 15 to 40% in patients who are diagnosed when the cancer has already metastasized. And here is one of the primary barriers to improving outcomes in oral cancer. Survival rates are pretty good if we detect it early. They're horrible if we detect it late. Yet, even in high-income countries, more than 2/3 of all oral cancers are diagnosed at an advanced stage. To make things even more challenging, people with high risk typically do not have access to early diagnosis. Now, in low and middle-income countries, 5-year survival is only about 10 to 40%. Why? Primarily because over 90% of all oral cancers are detected at an advanced stage in these populations. Let's take a look for a moment at the current path to oral cancer treatment to see at which stages of the process we might intervene to improve outcomes. The whole thing starts with a patient being screened by a hygienist, a dentist, a screener, a physician, or a nurse. And yet, typical screening accuracy is only 30 to 60%. Not much better than tossing a coin. So you go for your screening, and if the person screening you sees something that they consider suspicious, they will refer you to a specialist. Specialist takes a history, does a clinical exam, and takes a biopsy. The biopsy goes off to a pathology lab, it's processed, a pathologist looks at it, and sends a diagnosis back to the specialist, who then contacts the patient to get them into the pathway to care. Now, all of this depends on one major step: getting the patient to the specialist. And we can improve this step of the process, outcomes will improve exponentially. And that is one area that my group has worked on for many years, and this is the project I'm going to tell you about today. Why is it so difficult to detect oral cancer? It doesn't seem that hard to look in the mouth, does it? I mean, you just open it, you shine a light, and you look in. Well, take a look at these images for a minute. These are all people with lesions in the mouth. 2 of them are malignancy and a premalignancy. The other are simply an aphthous ulcer and a fungal infection. But you can't get them right, and nor can most screeners, because everything in the mouth is typically a white lump or a bump or an ulcer. And we cannot visually differentiate for the amount of risk a lesion carries by looking at it. This here is an aphthous ulcer. It looks horrible. This here is a fungal infection. It looks awful. Both of those resolve and are not life-threatening. It is these two, squamous cell carcinoma and a dysplasia, that are potentially life-threatening to our patients. That is why it is so difficult to screen for oral cancer. There are further complicating factors. First, you look in the mouth. You see a red or a white lump or a bump or an ulcer. We just talked about that. In addition, quite a few people have potentially premalignant lesions. Areas in the mouth that might become malignant sometime, or they might not. These are people we need to monitor constantly because we don't know which lesions will become malignant when or if they will. So we need to monitor them every few months. We have no way of doing it outside of a specialist office. We have a phenomenon called field cancerization, multiple lesions in the mouth. Some, none, or all of them may be visible to the naked eye. Well, how can we diagnose something if we cannot see it? Field cancerization, it's a problem. We have something called heterogeneity. If you have a lesion in the mouth, the severity of that lesion is very varied within the lesion. There may be squamous cell carcinoma right next to an area that's almost healthy, right next to an area that is potentially premalignant. When the specialists take surgical biopsies of lesions, typically they just pick a few sites. They may not hit the most severe site with their biopsy. So then the whole treatment planning becomes based on a biopsy that is non-representative of the risk of the entire lesion. All cancers recur. You see an area of previous squamous cell carcinoma. And finally, we have the HPV-related lesions, which tend to be underneath the floor of the mouth, in the lymphatic tissues, in the tonsils. Those are areas that we just cannot see. So let's take a look at what is done currently to screen patients, because it's a screening that gets patients into the pathway for care. Well, a lot of people are mandated to examine for oral cancer. Your hygienists, your dentists, nurses, physicians, community workers. We did a survey of these people a couple of years ago to see what they felt were the barriers to get patients into the pathway to care. And look at this graph down here. If you look at the reasons why clinicians did not screen for oral cancer, it wasn't billing, it wasn't no time. 85% of them said, I don't know how to do it. I'm no good at doing it. I have no tool for doing this. The barrier to better oral cancer outcomes, the primary barrier, the really important barrier is we need a tool to do this. Less than 50% of clinicians feel competent. That's not even counting community workers. What do clinicians currently do to screen for oral cancer? They check for risk factors. Do you smoke? Do you drink? Do you have a sore throat? Do you have an ulcer that's been there forever? History of cancer in the family? Then they look in the mouth. They feel your lymph nodes. And based on the combination of those, they decide on whether you need to be referred or not. Because this process is so challenging, some adjunct tools have been developed, some additional tools to help screeners. And indeed, some of these tools work quite well in specialist hands. Typically, they generate images such as this one here from the Valscope system, which then need to be interpreted. And again, if you're a specialist, you're used to these images. You can work with them. You know what you're looking for. These systems can be good. But our barrier to better outcomes is not the specialist. It's the screener. And these systems are expensive. They're difficult to use. They don't help screeners triage and decide what to do. So we have no good adjunct tools right now. Right now, all we can do is take a look, which is inaccurate, or take a biopsy, which is what specialists do. So, community health screeners or anyone else screening for oral cancer, their screening process is not accurate. Non-specialists typically have a screening accuracy of 30 to 60%. Not that much better than tossing a coin. And indeed, a lot of studies have shown that most community-based programs using non-specialists do not significantly improve oral cancer outcomes. So the challenge is very clearly defined. What's the solution? Well, we decided to approach this problem from the logistical end rather than the scientific end. And we asked ourselves, what do we need to give screeners, dentists, hygienists, community-based people to triage people better so that we get only the right people to specialists, but we get them to specialists early. Well, we developed a novel smartphone-based system that can image anywhere in the mouth and in the throat. It has an artificial intelligence algorithm that gives you an immediate screening outcome. It says, this patient's very low risk, they're fine. This patient has moderate risk, you need to keep an eye on them. This patient is high risk, get them to a specialist immediately. So it tells them what to do and the level of risk that's there. It's specifically aimed for non-specialists because that's where our barrier to better outcomes is. You can connect remotely with a specialist so that you can talk to them. You can have a video feed so they can see what you're looking at. And importantly, for screening, it's really low cost, it's robust, it's compact, and it's light. It looks like this. This rough-looking prototype on the left was the first prototype that we built. We made it with a 3D printer, and it's connected to a smartphone. You can see the smartphone here, the battery pack and the light sources are there. It runs through the optics of the phone, and here's the imaging head. We thought it was great. It was attached to a phone. We all hated it when we used it because it was so clumsy to try and hold a phone and move it around the mouth. It just didn't work very well. Sounded cool. Smartphone link sounds cool. But we learned that we need something that is not physically connected to a phone. So we built something that connects through a USB cord or remotely to a tablet or a laptop or an iPhone. It's kind of like an electric toothbrush, except it has a bendable, very soft head. It has a wide range autofocus so we can see all the way to the back of the mouth, under the tongue, without hurting our patients. How does it work? I'm sure you've all tried looking at something in bright sunlight and haven't been able to see it very well until you put on your polarized sunglasses. And all of a sudden you could see much clearer and much better without glare, with less reflection. And similarly, our smartphone probe uses polarized white light so that we can see the structures in the mouth carefully and clearly, and that feeds into better artificial intelligence outcomes. In addition to using polarized white light, we use various colors of light to shine onto the tissues and make them glow or autofluoresce. Premalignant and malignant tissues fluoresce differently from healthy ones. So we have our polarized white light image, we have a bunch of colored autofluorescence images. We combine those with the usual risk factors that we've put into the phone, and all goes into the artificial intelligence algorithm, and out comes a risk factor analysis. The soft adaptive probe allows us to see the HPV-related lesions in the back of the throat, at the floor of the mouth. We can see a large area quickly because screeners are always in a hurry. And we can immediately see the images on our smartphone or on the tablet. This is what the images look like. Here on the left-hand side, a polarized white light image of the inside of your lower lip. And if you look carefully, you can see it's the normal healthy pink color with some white splodges around it. You can see quite clearly, despite the little bit of glare that's left. We can see these features so clearly because of the good optics on this system. The second image is of the area at the base of the tongue, underneath the base of the back of your tongue. It's an important site because HPV-related lesions are often there. We can't see them with the naked eye. Again, a very clear image here. Image C is of the tonsils at the back of your mouth. You can see the different lobes of the tonsils, and you can see the blood vessels very clearly. Underneath here, a photo of an area at the back of the mouth where you can see red and white color changes in the tissues and some tiny micro ulcers. So clearly the optics of the system works pretty well. Now, what happens next? We've put in our risk factors from a drop-down list of risk factors. We've taken our photos. The whole thing goes through the artificial intelligence algorithm, then two things happen. The first thing is our image on the screen gets what's called a pseudo color overlay. The artificial intelligence algorithm colors in green areas that have oral cancer, or in white areas that have a pathology, but it's not cancer or precancer. So the screener can see right away, aha, these are the areas of interest. These are the areas that I need to focus on. Do I need to connect with a specialist? Do I need more photos? Do I need to talk to one? In addition, we have coming up on the screen this very simple output that just says very low risk, do nothing, moderate risk, monitor, high risk, connect with specialists immediately. So it takes the screener through the steps of what they should be doing. Once we had the system, we decided to test it here at the University of California, Irvine, and at 3 centers in India. Why did we choose India? There's a lot of oral cancer in India, and we have some highly skilled specialists in oral cancer there who worked with us. I should add at this stage that a lot of the technology was developed together with Dr. Ron Liang's group at the University of Arizona in Tucson, and I want to make sure that he gets a mention here as well. So, how good was the performance of this remote screening system? We screened almost 10,000 subjects, and what we did was we got in people who had red or white lesions in the mouth or some kind of lumps or bumps or felt they had something in their mouths. And we got community screeners first to do a conventional screening with a clinical evaluation and risk factors. Then in the same patient to do a clinical evaluation and risk factors, but also look at the probe image like this image here or here, allowing them to see better in the back of the mouth or underneath the floor of the tongue. And then we just looked at what is the artificial intelligence diagnosis from our algorithm. Take a look. This is interesting. In healthy people, the screeners alone had about 75% accuracy. People with dysplasia, so lesions that might become malignant in future, we had less than 50% accuracy in screeners. Same for carcinoma. Patients who had something other than healthy dysplastic or carcinoma, screeners had about 55% accuracy. So overall accuracy was only about 56%. This is a conventional screening by pretty well-trained screeners. So it fell right within the range of what we see in the literature, so we knew that our technique was good. We then had the screeners do the same thing but add in the probe image. I think it made them nervous. Look at this. In healthy patients, screening accuracy was worse than without the device. It was about 10% better in dysplasias and about 15% better in carcinomas, 10% better in other lesions. So our overall screening accuracy was now at least a bit over 60%. But, you know, when your life depends on the screener, 64.3% isn't very reassuring. Then we looked at the diagnosis from the screening algorithm. It diagnosed healthy individuals 90% of the time, dysplasia or potential premalignancy 82% of the time, carcinoma 88% of the time, for an overall diagnostic or screening accuracy of about 86%. Not perfect, but way better than 64 or 56%. So clearly the system works. And in collaboration with our friends in India, and now also in the United States, we are continuing to test the system, collect more data, to keep refining the artificial intelligence and make it more accurate yet. So in conclusion, we developed a novel smartphone or tablet-based solution for screening for oral cancer, for detecting it early. We developed proprietary artificial intelligence for screening and triage guidance that allows earlier detection, more accurate referral. Earlier detection and more accurate referral lead to earlier care and better outcomes. This system is compatible with nearly every smartphone and tablet, including very simple ones. It's very inexpensive and it's easy to use. What's next? I've told you about just one piece of the puzzle, the low-cost screening end of it. This system is connected to our high-performance specialist tool that we're also working on that will map lesion heterogeneity, map margins, identify the best places for biopsying sites, and provide preoperative and intraoperative guidance to specialists and surgeons. I'd like to acknowledge all of our collaborators on this project and thank them. We couldn't have done it without them. Thank you for listening to my presentation today.
My name is Nimi Ramanujam, and I'm a professor at Duke University in Biomedical Engineering and Global Health, and I also direct the Center for Global Women's Health Technologies at Duke. We are really committed to addressing a challenge, a cancer challenge that is really being prioritized on the international stage, cervical cancer prevention. And what we have realized is that we need to take an approach for cervical cancer prevention that is really inspired by women themselves. And the reason for this is, like other sexual and reproductive challenges, one sort of common denominator between cervical cancer prevention and other reproductive health issues is that you're dealing with a private part of the body, and there are a lot of cultural barriers that come with that. So I'll tell you a little bit about how we're using this strategy in the context of cervical cancer prevention globally. So I'd like to start off with some graphs. The first graph shows the thousands of deaths of women in developed countries and developing countries as it relates to cervical cancer mortality. And what you can see is that while the number of deaths is pretty constant and low in developed countries, you see that it's relatively higher in developing countries, but perhaps what the most important aspect of this graph is that the death rates are actually rising over time. So really the goal is to avert this trajectory. So one might think, okay, we have proven solutions and we have a vaccine. Why don't we vaccinate everyone? And the problem is vaccination doesn't work for women that have the HPV virus, which causes cervical cancer. And also, there's actually a shortage of vaccines. And so supply doesn't meet demand. So we need strategies that can really address cervical cancer prevention in adult women that have the HPV virus. If we don't, and we only rely on vaccination, we stand to lose a full generation of women for whom vaccination doesn't work. So what is the WISH revolution? It is really a strategy to create a woman-centered model for cervical cancer prevention. Why? Because there are structural or logistical barriers such as distance to a health facility, cost, etc. But there are also cultural barriers such as shame and stigma, lack of awareness, and just fear. And so when we think of a solution, we need to address both cultural and logistical barriers. And the way that we're approaching this is through technology, but just not with technology alone. So one of the key capabilities we've developed is visualization in a way that is digital and one that can look at really small features that the naked eye cannot do. The second is to be able to make decisions at the point of care when there's a shortage of experts who can render a diagnosis and then make a decision on follow-up care. And the third component is education and empowerment. In other words, if you have all the technologies available to you, but women don't show up, then you really haven't solved a problem. And so what we want to do is not only educate, but create peer-to-peer networks where they share stories and they're able to essentially advocate for each other. And that creates a ripple effect and could amplify what we do in a community. And so what is the expectation with this particular set of solutions? And that is that we want to essentially be able to do three things. We want to be able to have women actually take control of the entire screening process, whether it's molecular testing or imaging, and only to have to go to a health center if they need treatment. Further, we want to make sure that we have all the tools available for women who need additional care at that local health center, and so that women can get treated by individuals that they can relate to. And of course, being at a local health center means that you don't have to travel long distances. And we want to create a cascading effect where we can essentially have community health providers from the community actually empower the women as a way of creating the demand that is needed to essentially screen for cervical cancer early and then follow up with appropriate treatment. So I mentioned that cervical cancer prevention entails a three-visit model. And this is largely what has been successful in developed countries. There's a screen, diagnose, and treatment phase, and each of them typically involves different touch points. And so what would it look like if you could consolidate those three touch points into one? And the way that we're proposing to do it is to essentially bring screening to a woman's home with imaging, and then decision-making can be used to determine if she has to come to a health center. And if she does, then to be able to have all the tools to identify, diagnose, and treat disease at the same time. And what is really distinct about this approach is that the majority of women with HPV don't actually get cervical cancer. So for every 100 women that are screened, really 98 can complete care at home, and only 2 would ever need to visit a health center. On the flip side, for every 100 women that are screened, you can save 2 lives. So there have been a number of technologies that have been developed for cervical cancer prevention. And so what we want to do is really put together a package of technologies that can achieve the goals I just described. So the WHO has already approved a treatment modality which involves ablation of the cervix with heat, and that's shown in the middle. And there are a lot of efforts to develop artificial intelligence algorithms. Our group is doing it, as well as others, to essentially automate the process of diagnosis. And the link between the two is really being able to image the cervix. And so what we have done is developed a device called the pocket colposcope, which is not only portable, but it's the price of an SLR camera, and it can really be used in a way that provides high quality images, but a significantly lower cost than a traditional colposcope that is used in a hospital. So what this implies is that we can bring the tools that are traditionally used in hospitals to the point of care setting where the woman lives. Furthermore, we can also in the long term, replace the expert with a virtual algorithm. Now, it doesn't end there. There are some women that get cancer, and so our goal is to really create linkages so that for women with cancer, we have appropriate bioinformatics platforms and communication linkages to do that. So I wanted to talk a little bit about the pocket colposcope. It's really a handheld device that has an entirely different form factor compared to the traditional colposcope that's seen at the top here. And you can see that fundamentally the design allows you to really drive down the form factor, make it easy to use. It's kind of like essentially a wand that you can control by placing on the speculum. And importantly, it really provides images that are comparable to a high-end colposcope, as shown on the right, where you have a normal cervix, a low-grade, medium-grade cervical precancer, and then a full-blown cancer. A physician can essentially look at both of those sets of images and render the same diagnosis. So I talked about the model of see and treat in a health center, but what's really exciting to us is the idea of moving some of those services, particularly screening, to the woman's home. So HPV testing, it's a molecular test that looks for the HPV virus that causes cervical cancer. And traditionally it was done in a clinic, but studies have shown that it has similar efficacy when done by women at home. And in fact, we're working with a community in Peru that's just doing that, which is community health workers are going to women's homes or to the markets to disseminate self-HPV testing kits. And it turns out that more than 50% of the women who have taken this test and gotten results never had been screened before. But what if you could combine another screening test, which has traditionally been called visual inspection with acetic acid? This is where a provider actually looks at the cervix after applying vinegar and looking for abnormal lesions, but this is done with the naked eye. What if we could modify the colposcope in a way that allows that same information to be obtained with magnification and also be done as a self-exam? And so that requires a specific technology that women can use themselves. And this hasn't been possible because of the speculum, which is a mainstay in a gynecological exam that allows the provider to have a clear line of sight to the cervix at the end of the vaginal canal. And it really hasn't changed in the last 200 years. And what's interesting is we've come a long way with technology in terms of computational technologies. Now you have a computer on your phone, but yet these traditional technologies like the speculum or devices like the speculum have changed very little and were developed in a culture that was very patriarchal. So we had an idea. We thought, we have the pocket colposcope. What if we could design a way that would obviate the need for a speculum? And we were inspired by the design of a calla lily, or the shape of a calla lily with its stem, to think about a speculum or replacement for the speculum, which essentially looks like the coloscope shown here. And then we could just simply insert the camera in, and a woman could essentially use this like a tampon and insert it into the vagina. And what you can see here is a woman actually doing a self-exam where she inserts the coloscope and she's able to essentially at the end rotate the tip, and then lo and behold, you can see the cervix centered as reflected by the os, which is essentially the opening to the uterus. So I talked about AI earlier and the importance of being able to make decisions in the absence of an expert. And so what we have done, as well as others, is developed artificial intelligence algorithms to be able to replace an expert colposcopist. We don't expect it to be perfect, but the question is, can it do as well as an expert colposcopist? And that's what you see on the right. We did apply this algorithm to a significantly large data set, And then we had 3 experts actually review the same data in a blinded manner, and then we use pathology as the gold standard. And you can see that the algorithm outperformed the 3 experts with a collective experience of more than 100 years. So the idea here with the WISH model, as I said earlier, is to essentially take the barriers away that women face when it comes to advocating for themselves, as well as being able to afford or make it to the places that she needs to get the care that she needs. And so the way we thought about it is, how can we consolidate the services that are provided to make them as simple as possible? And so that's what basically led to the one visit model. And the second was, even with the one visit model, if women are trepidatious about the nature of the exam and issues over privacy, then could we develop technologies that could be brought to a woman's home? And that has 2 advantages. One is it allows the majority of women to get screened, which is really important because most of the women are actually don't have precancerous lesions. And also, if a woman develops a precancerous lesion later in the course of her life, by creating this model where it's done in the community, a woman can get self-tested periodically. It isn't a one-time test. And then for the visit that the women have to make, it's really a very small subset that have to go. And yes, you would need a speculum-based exam, but the upside is that if it's done in a community setting, it would be done by midwives and nurses who the women could be more comfortable with during a pelvic exam. We have implemented our technologies in a variety of countries across the globe, including South America, Africa, and South Asia, as well as in the United States. And so we've created these partnerships with all of these clinical partners that we've worked with over the last decade as a way of informing both the development of the technology as well as how it should be integrated into care. And one has to recognize that with cervical cancer prevention, it is quite different across different healthcare settings. The types of tests that are used, and whether it's a see and treat or a 3-visit model, these are all variables that we have to contend with. So it's really important that when we develop these tools and integrate them into healthcare systems, we're thinking about the healthcare systems by their geography. So we have incorporated this model into our development so that we don't end up with a problem when we start to scale our solution. So I'd like to end there with my presentation.
Thank you for your presentations. It's now time to move to the moderated Q&A section. Presenters, please feel free to show your videos.
Thanks very much, Dr. Kingham, Dr. Wilder-Smith, and Dr. Amunijam, for your truly fascinating presentations that I thought were terrific and lead to improving global health disparities and improving international health. So now we'll begin our questions and answers session with a panelist. As a reminder, the chat feature will be disabled during this segment, but you can participate in several other ways. You can use the raise hand feature located at the bottom of your screen to indicate you have a question or comment, and we will enable the audio so that you can speak. Or you can ask questions and comments in the Q&A text feature, also located at the bottom of your screen. We will go to raised hands first for your questions, and then to the Q&A. Please keep your hand raised so that we can call on you in the order hands were raised. And again, a reminder, please don't use the chat feature because we won't be looking at it. So in one way or another, we'll try to get to all or as many of your questions as time permits.
All right, looks like we have a raised hand from Gina.
Go ahead.
Gina, go ahead and ask your question. And you will have to unmute your own mic.
Gina, your mic is still muted.
We are moving on to Norma. Norma, go ahead and ask your question.
Norma, your mic is still muted.
Here we go. I think you can hear me now, right?
Yes.
This question is for Dr. Peter Kingham that talked about the high risk for breast cancer women in Nigeria. The baseline tumors displayed by these women were maybe 3 or 4 centimeters, I believe, in size. And my question is, the reason, do you think the reason of the fast, is it that the tumors are fast growing or the women were not paying attention?
Norma, thank you for your question. It's a very good one. There's a couple of different data points I'll share with you. The median tumor size for a woman at the centers in our consortium, Argo in Nigeria, who presents with breast cancer is about 9 centimeters, which is very large. Most women come in with T3 or T4 tumors. And while there is generally thought to be a higher percentage of triple negative breast cancers, which is more aggressive breast cancer biologically, usually this is the reason the presentation is so late is because of delays in presentation, but often not only because of patients being unaware of breast health and the need for breast screening. Other studies we've done have found that there are often significant delays in the health system at the community health level, and women will present with breast masses but not be worked up and forwarded on to larger centers for actual staging and care. So there's really systematic problems where the delays are, and also there's a big need for patient education, and I think it's a combination of all of those.
Thank you.
We're going to go back to Gina for your raised hand. Go ahead and ask your question. Gina, you will have to unmute your own microphone. We'll come back to Gina. Next question will be from Ray. Go ahead and ask your question.
Can you hear me? Okay. Two quick questions. How are you using telemedicine mobile units in your screening process, and what would be the role of medical units to reach out to the population and do treatment, screenings, and biopsies on site? In addition to all of the panelists.
Go ahead, Dr. Wilder-Smith, go ahead, please.
Thank you for your question. It's a really good one because, of course, screening and diagnosis only improve outcomes if we do something about the information that we get. And it's kind of an interesting question because it ties into logistics. And logistics are so important to outcomes, and they're not as cool or as sexy as science or artificial intelligence, but they really matter. For our work in India, we're very fortunate to work with one of the largest cancer foundations there called Biocon, as well as several cancer centers and dental schools. And what they have is they provide a van service and a system of roving community workers and specialists who, once the screening is performed, those people who need further care are then provided with transportation and appointments with the appropriate specialists to see that they get a full diagnosis and treatment. So, of course, our project is, if you like, it's larger than a pilot project, but it's clearly not a healthcare system. And so what we are doing is as we improve our screening capabilities and logistics, we're simultaneously building the pathway to care for the people who are identified by our screening process. And that ties into everything from medical IDs for everyone to making sure that people have a way of getting to treatment, to seeing that their care is paid for, to thinking about follow-up and where they're going to stay during care. So it becomes a quite comprehensive undertaking, and it's a really important one because in the end, our outcomes are only as good as our pathway to care that follows up on the screening. So thank you for this question.
Dr. Kingham or Dr. Amunajam, any additional comments? You're muted, Peter.
Yeah, we're not using telemedicine directly in this study with the iBreast, but there are other uses for it in the screening programs that we're working on, which is really because it's a point of care test. So there's a positive immediately. So the next step in patient care is established at the point of application of the device. But what is really most useful, I think, in the system that we're trying to develop is follow-up information about future appointments, where you're getting your mammogram or ultrasound and biopsy results. So it's further down the line than the actual screen with either clinical breast examination or the iBreast device. But there is a big need to minimize barriers of logistics by using telemedicine.
Thanks. Dr. Amunajam? You're muted.
I know. It just took me a while. We are definitely leveraging telemedicine. So right now, the model is for HPV testing, there isn't really telemedicine per se because the tests are collected in a common repository and then processed in a central facility, and then the women get a text message. And then the community health providers actually make sure they get to the next step of care. For imaging, telemedicine does become important because based on policy as well as access, experts do need to weigh in on what the diagnosis should be. So you can't sort of replace that with community health providers. And also, especially during this time with social distancing, that has become even more important and is actually perhaps something that will stay and even grow because of the fact that healthcare is changing in the COVID-19 era. So our idea with AI is not to say we don't need a real expert, but as the world moves towards using AI algorithms, and I know that that's all the rage right now, we can't just bring that in right away. It has to be phased in, just like home testing has to be phased in. And so what we're doing is first using telemedicine, then using a hybrid approach where the virtual expert can just thought of as another reader. And then ultimately what we hope to do is wean ourselves off the real experts and then go into the virtual expert entirely. This is going to take changes in policy and practice, which are not easy to address. That requires us to work with stakeholders and alongside them and work within the constraints of both logistics, cost, internet access, and also what professionals are willing to do outside of the health facility. So it's a long-winded answer, basically to say that in an ideal setting, we'd want to do the most efficient way of delivering care, but there are also barriers that are geographically relevant that we have to consider every time we implement a new model of care.
Thank you very much. Please post your emails on the chat line. I would be very happy to follow up with you around the issues of medical mobile units.
Thank you, Ray. We have another questioner.
We have a silver raised hand from Gina. Please unmute your microphone so we can hear you.
Still not working, unfortunately. Maybe
Next we have Norma with a raised hand. Please unmute your microphone so we can hear you.
Yes, this question has to do with Dr. Nimi from the Hope Project. Is that correct? Did I say her name right? I'm not sure. But anyway, I was wondering about the women who do the cervical cancer screening using new technologies at home. Will that alleviate the co-payment that these women would have had to pay had they gone into their health center or clinics?
Thank you, Norma. Well, it depends. So in Peru, for example, cervical cancer screening is actually provided for free, with public insurance, which is basically given if you don't have private insurance or don't visit a private health facility. So as I mentioned earlier, even with the public, with cervical cancer screening, offered completely free, only, I would say 30 to 50% of women actually use it. So it's very important for us to, so there are many countries where cervical cancer prevention is important, but when we selected our target countries to work in, where we wanted to go deep, we started off with the premise that is cervical cancer screening provided, as well as other services? Is there a well-established program? And is the government already investing in those services? Because we didn't want to start with a blank slate because that creates additional hurdles. We wanted to test the system that we are bringing in, and we wanted to show a return on investment, because if they're providing public screening, screening as a public service or for free, and women aren't using it, that means that their investments are not paying off. So that was the criterion we used when we selected our partner country. So rather than thinking of it as a co-payment, I would say in our particular scenario, it was literally the 8 bus rides that women had to take to make it to a health facility, even if it was free. So what we tried to address are the barriers that we heard from women in the communities we work in. For example, Ventanilla, which is essentially a desert, near the airport outside of Lima. And women basically said, we're scared. We don't like the speculum-based exam. It takes us a long time to go, so it's an opportunity cost. And so they don't end up going. And of course, there's this lack of awareness. So if it's not, a mole on your skin, or if it doesn't have symptoms, it's hard to say that's a priority when you have a million other responsibilities. So our specific goal was to address barriers related to distance, lack of access, because of social barriers, and addressing those in a situation where the public sector had already made an investment.
Thank you.
Okay.
We have a raised hand from Purnima. Please unmute your microphone so we can hear you speak.
Hi, I'm actually sitting with Purnima. My name is Carl Krupp. I'm from the University of Arizona. I have a question for Dr. Wildersmith. as you mentioned, oral pharyngeal cancer is an HPV cancer. I wondered if you had considered or used HPV testing along with your examination, and what impact you think that might have on increasing sensitivity or specificity.
Thank you for your question. It's a really good one, and it's something that we've more than thought about, probably agonized over is a better way of putting it. HPV is a huge problem, not in all countries, but in many countries. And of course, if we know someone is HPV positive, that really changes the way that we examine them and the way that we treat them and the way that they respond to treatment. It's not something that we have done, in part because there are still not really reliable HPV tests that cover the whole range of HPVs that might be of interest. And also because, like Dr. Ramanujan, we have worked really hard to integrate what we are doing into existing programs and into addressing the lowest barriers, if you like, to improving outcomes. And as you probably know, HPV can be quite an emotive issue. And it has often become a topic that needs to be moved a little further down the line of discussions in order not to stymie the things that we can do. So it's a logistical challenge, it's a emotional and a perceptual challenge, if you like. And it's one that we need to address. I see it as something we need to address within the next couple of years or so. But right now, it's not something that we do.
That's the next question. Okay.
Do you have any additional questions?
Yeah, I have one other question, and it's actually directed to Dr. Kingham's. There's a number of piezoelectric finger systems out there. I wondered, I didn't, maybe I missed it, but I didn't understand whether he had developed his device or whether he was using a commercially available device.
Yes, the iBreast device is commercially available. I and all our team here at Sloan Kettering in Nigeria have no connection at all to the development of it. Our interest in studying this is that there has been some work on it done in the US at the University of Pennsylvania, and we saw those data. The company has also done a fair amount of work with women in India, and so that drew our attention to it. But we have nothing to do with all of the development of it. Our interest really is in just properly studying it.
Thank you. Thank you both.
Thank you.
We have a raised hand from Erica. Please unmute your microphone so that we can hear you.
Hi, I'm Erica Bailey in New York City, and I wondered with the iBreast study, when will those, where could I find the published results once that's available?
Yeah, so there's publications out of University of Pennsylvania, and there have been publications out of India. Our work that Prevent Cancer Foundation funded, we hopefully will have our analysis done in about a month and be submitting something so that it would be in publication by the fall. And my name I'll be one of the authors on it, Kingham. So you'll be able to find it that way, or if you send me an email, I'm happy to correspond with you about it.
Thanks, Peter. Any other questions? Peter, I have one for you about the other factors that you mentioned that weren't typical for predisposition to breast cancer. Would you like to speculate?
Yes, there's, for a while now, we and others have shown that women in many sub-Saharan African countries where breast cancer rates are really rising quickly have what we think of as protective factors. So most women are younger, they have multiple children, they breastfeed, all things that we think of as protective. So there are clearly additional factors that are at play here that are different than what we traditionally think contribute to breast cancer risk. We have a couple studies going on looking at this right now. So one is a study looking at white adipose tissue inflammation, and that as an independent risk factor for breast cancer, because as industrialization and lack of rural living environment takes hold in countries like Nigeria, weights are rising, and it may be that there are some parts of this risk that are being affected by or contributed to by obesity and inflammation. So that's one thing. The other thing we're doing is we've created a questionnaire specifically for West African diets and exercise patterns to try and do a case control study for starting in colorectal cancer, but then breast cancer as well, to try and get some better answers for this.
Thank you. Any other questions on the raised hands?
We currently do not have any raised hands questions.
Do we have any on the Q&A?
We did just get a raised hand. Oh, and it was lowered. We do have Q&A questions.
Okay. Who's the raised hand?
They have since lowered their hand.
Oh, okay. How about Q&A?
Oh. A question from the Q&A is, could the Kala AI be used in postmenopausal women?
Yes. The short answer is there is no restriction to who can use it. And in fact, there's little restriction to, what other reproductive health services can be used for. For example, we wrote a Medium article where we talked about the fact that, if you're a woman in labor, or if you have other reproductive health issues, or simply if you want to learn about your reproductive anatomy, you could use it for any number of those things, particularly at a time where access to a health facility right away may not be possible. We have found out that in postmenopausal women, as well as women that have had radiation treatment for cervical cancer, anytime that there is pain associated with a speculum or other reasons that would basically lead to increased pain, the coloscope is readily usable. But our focus is to obviously show that this could be a way to close the gap between the patient and screening.
I have another question for you. What about a power source? Do these women have that, and how do you?
Yeah, that's a great question. So the coloscope is powered by a cell phone. So when we have introduced this in Ghana, in Peru, and the US, women either use it themselves in a clinical setting, which is one option. And in the other scenario, women take it home and they do it. And then we do basically an interview afterwards, asking them how they felt and what their experience was like. And then, so basically it is just like the pocket colposcope in that it doesn't need an external power source, it doesn't need AC power. And we have a tutorial, but we found out, for example, in Ghana, where there were some time constraints, that it was fairly intuitive for women to use it. You insert it like a tampon, and it has a tip that essentially nudges cervices that are tilted away, so that if you don't have a clear line of sight to the camera, the camera doesn't have a clear line of sight, the shape of the introducer, the calla lily flower shape, is key in being able to position the cervix so that the woman doesn't have to figure out whether A, she's seen her cervix, and B, if she has it in the right location. And of course, they're shown images so they know what they should expect in terms of what a cervix should look like.
Thank you. Yeah, interesting question. How did each of the panelists, reduce the fear and anxiety after a patient learns of a result that requires a follow-up, particularly in settings with access issues or a lack of sophisticated understanding about the next steps and the implications thereof?
Is that for me?
It's for each of you.
Oh, okay.
So why don't you start, Dr. Wilder-Smith?
Thank you for that question. Most of our work has been done in India. And what we have learned to do is, excuse me, as we plan a visit to let's say, a remote village, we have an advanced team of 1 or 2 individuals who will go to that village, and they will seek to identify, if you like, the senior lady in the village. Typically, a lady who has at least a 3rd grade level education, who perhaps has some authority or social standing in the village. And she will kind of be our enforcer, if you like. She's the one who helps us to recruit patients, to make sure everyone comes, and who also stays with the people who are being screened and assists with the communication process. Typically, this person will also be involved in us figuring out how best to communicate the results and then how to set up the logistics for follow-up as needed. We found that by pulling in a known person, especially perhaps an older lady within a village, it gives the individuals being screened a sense of perspective, a sense of security, a sense that someone whom they know thinks this is okay. And we found that once we started doing this, not only were our participation rates really, really good, but we were also able to greatly increase participation in follow-up and pathway to care. When we started these studies in patients who screened positive for needing to go to a specialist for diagnosis, we only had about 40% of individuals within 6 months who agreed to follow up. So it was a big barrier to improving outcomes. And so we tried various models. And using this model, we're up to over 90% of individuals who have a positive screening, being compliant with follow-up within 1 month. So this model works well for us in India.
Thank you. Peter, Dr. Kimmel?
Yeah, it's a very important aspect of all of this. Not one that I would say we have figured out, but one that we care a lot about and are paying a lot of attention to. To simplify it, there are financial barriers, and then there are personal beliefs and cultural beliefs and fears. The financial barriers in Nigeria specifically, everything is self-pay, so that becomes a major barrier. Only 5% of the population is covered by any insurance. So that we can assist with when we're doing our research studies, but then there are also just cultural beliefs. And so a lot of that is relying on practitioners who have been in the community for a long time to be a part of the screening. What we have found for breast cancer specifically is women are extremely eager to participate in screening, and there so far has been a low rate of women. 3 out of the 37 women who were recommended to have a biopsy didn't get them. So the majority of women were okay with carrying on with the biopsy, but something we're still capturing a lot of data on and doing some real qualitative work on to try and figure out how we best contribute or help alleviate a lot of the fears in carrying on once there are positive results.
Thank you. I'm sorry, Dr. Ramunajan, we're just out of time, but I know that you probably have thought through this yourself. So I would like to, on behalf of the Prevent Cancer Foundation, thank these speakers. They just did a terrific job. Also, there are behind-the-scenes people at the foundation and at Marquis, who I also want to thank for just doing so well. So it's time to adjourn, but please stay tuned for the fireside chat about blood-based cancer screening with the sponsor Guardant Health. And that's followed by poster presenters who have undoubtedly some very interesting projects to talk about in cancer prevention and early detection. So thank you all for being here and participating.
Thank you.